Welcome to this Step 3 review on discharge planning. This video is brought to you by Roadmap to Residency. Discharge planning questions are a favorite on Step 3 because they test whether you can safely move a patient out of the hospital or clinic and into the next phase of care. Our goal today is not to reteach every detail of discharge medicine. It is to show you how these question stems are built around one missing piece of a safe transition and how to attack them. Make sure you are also working through your question bank and a solid review resource alongside this video because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn to read the discharge vignette and ask what step is still missing before this patient can safely leave. Then we will walk through the 4 discharge domains the test loves: the discharge summary, medication reconciliation, follow-up appointments, and red flags with return precautions. We will do practice questions in each area and learn to recognize the classic answer traps so you can pick the safe and complete choice. Remember, this video is about test-taking strategy, so keep your question bank open alongside it. Our first strategy is to find what is missing for a safe discharge. Read the last line of the stem first, because it tells you exactly what is being asked, whether that is the next step before discharge, what to include in the plan, or what to tell the patient at the door. Then go back into the stem and hunt for the unfinished step. Discharge questions are almost always built around one gap: a medication that was never reconciled, a follow-up that was never arranged, or a warning sign the patient was never taught. Find that gap, and you have usually found the answer. Strategy 2 is the safe discharge mindset. A patient is ready to leave when the acute problem is stabilized, the vital signs are acceptable, and there is a reliable plan to continue care at home. Be suspicious of any answer that sends a patient out with an unaddressed danger sign, a medication list that was never reconciled, or no real way to follow up. The exam rewards closing the loop. The best answer confirms the medications are reconciled, the follow-up is arranged, the patient knows the warning signs, and the next provider gets a clear summary. When 2 answers look reasonable, choose the one that completes the safe transition. Let us put the 4 discharge domains in one place, because almost every discharge question lives in one of them. Domain 1 is the discharge summary, the handoff to the next provider, which should include the reason for admission, what happened in the hospital, the reconciled medication list, pending results, and the follow-up plan. Domain 2 is medication reconciliation, where you compare home, hospital, and discharge medications to catch omissions, duplications, and dose errors. Domain 3 is follow-up appointments, which should name who the patient sees and how soon, with higher-risk patients needing earlier and clearly arranged follow-up. Domain 4 is red flags and return precautions, where the patient must learn the specific warning signs that should bring them back. When a choice skips any of these, treat it as incomplete. Let us work through our first practice question, and this one is all about medication reconciliation. We have a 70-year-old man with heart failure and atrial fibrillation being discharged after a fluid overload admission. At home, he took warfarin, metoprolol, and furosemide. During the admission, his furosemide was increased and apixaban was started, but nobody documented stopping the warfarin. So now he is on 2 blood thinners. His daughter asks for the updated list, and we are asked for the most appropriate next step before discharge. Pause here and read the last line, then look for the gap. Notice that the danger is the unresolved overlap of 2 anticoagulants. Take a moment to choose your answer before we break it down. Let us break this down step by step. First, spot the pattern. The stem hands you a reconciliation conflict. A home blood thinner was never formally stopped while a new one was started, so the patient is on 2 anticoagulants at once. This is the classic omission and duplication error that medication reconciliation is designed to catch. Next, apply the rule. Before the patient leaves, you reconcile by comparing home, hospital, and discharge medications and resolving every discrepancy, which here means clarifying that the new agent replaces the old one so the patient goes home on a single correct blood thinner. So the answer is choice B: reconcile the medications and resolve the overlap. Now eliminate the rest. Handing over the list without reconciling ignores a dangerous duplication. Knowingly continuing both blood thinners leaves a real bleeding risk. Stopping all anticoagulation exposes a patient with atrial fibrillation to stroke. The answer is choice B. Here is our second practice question, and it is about arranging follow-up. We have a 58-year-old woman discharged after a community-acquired pneumonia admission. She is improving on oral antibiotics and is stable. Her chest imaging showed a possible nodule that needs repeat imaging to confirm it resolves, and the team noted it in the chart. She has reliable transportation and a primary care provider. We are asked for the most appropriate next step before discharge. Read the last line, then find the pending item that cannot be left floating. Take a moment and pick your answer before we go through it. Let us work through this answer. First, find the pending item. The stem plants a nodule that needs repeat imaging to confirm it resolves, and a safe discharge cannot leave that finding floating with no owner. Next, think about why a specific plan wins. Arranging a specific primary care follow-up and making sure the nodule plan is communicated closes the loop and manages the whole patient over time, which is exactly the behavior Step 3 rewards. So the answer is choice B, now the distractors. Telling her to simply return if she feels worse abandons the pending result. Repeat imaging in 2 years is far too late for a nodule that needs timely confirmation. Sending her straight to a biopsy is overkill for an incidental finding. The answer is choice B, arrange specific follow-up and communicate the plan. Let us talk about the discharge summary, because it is the handoff that ties everything together. Picture it as the baton in a relay race. The provider who picks up this patient next needs the reason for admission, the key events and treatments, the final reconciled medication list, any pending results, and the specific follow-up plan. On the exam, the best answer is the one that makes sure this information actually reaches the next provider. Many discharge questions hide a dropped baton, a pending culture that no one is set to follow, a medication change that was never written down, or a follow-up that was never booked. When you spot an unfinished handoff like that, the correct answer is the choice that completes the communication before the patient leaves, not the one that simply sends them out the door. Here is our third practice question, and it is about return precautions. We have a 45-year-old man discharged from the emergency department after a mild concussion from a fall. His head imaging is normal, and his neurologic exam is normal. He lives with his spouse, who can observe him, and he asks what he should watch for at home. We are asked for the most appropriate instruction to give before discharge. Read the last line and notice that the missing piece is what to teach him, not more testing. Take a moment to choose your answer before we work through it. Let us break down this answer. First, find the safety gap. Even with normal imaging and a normal exam, a head injury patient can still deteriorate at home, so the missing step in this discharge is teaching the patient and his spouse the specific warning signs that should prompt an immediate return. That teaching is the safe discharge step. Now the key distinction. Teaching concrete return precautions, such as a worsening headache, repeated vomiting, confusion, or weakness, is the complete and appropriate answer, which is choice B. Reassurance alone ignores the risk of late deterioration. Prolonged darkroom bed rest is outdated advice. A routine repeat scan with no symptoms is unnecessary testing. Each wrong choice either skips the safety teaching or adds care the patient does not need. The answer is choice B, teach specific return precautions. Here is a critical exam day pearl that ties all of our discharge thinking together. Run a quick mental checklist on every discharge question. First check, is the patient safe? Ask whether the acute issue is stabilized and whether it is safe for this patient to leave, and if an answer sends an unstable patient home or ignores a clear danger sign, eliminate it right away. Second check, is the loop closed? Ask whether the medications are reconciled, the follow-up is arranged, the return precautions are taught, and the summary is communicated to the next provider. The correct answer is usually the single choice that fills the one open item in the stem. Train yourself to pick the option that completes the safe transition, and discharge questions become much faster and much cleaner. That wraps up our review of discharge planning question strategy. Keep drilling these questions in your question bank until the safe and complete choice feels automatic, and pay attention to which of the 4 discharge domains each question is testing. Read every explanation, even for the questions you got right, and keep practicing under timed conditions, so reconciliation, follow-up, and return precautions all become second nature. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.